Happy evening, friends. Today I thought that I'll try to discuss something about the use of artificial intelligence in medical practice. Uh, Now we see AI everywhere, but in the medical practice, of late I've got some offers from various concerns in the for the tuning of the artificial intelligence in the medical field. So I was just wondering, generally, superficially, about what the problems could be. I mean, the basic issues, not going too deep into it, but then uh, uh, compared to any other field like engineering, law, whatever. So, first, when I thought of artificial intelligence, it was just like the time when the computers came, when there was all data available on the computers. That was the time when I started looking at certain, for example, medicines itself, the side effects and all that. I found myself wanting, in the sense that it was a very comprehensive, extensive detail about everything. The thing is, too much of everything only causes confusion. And later on, while having to deal with patients, uh, now it has come down because most of my patients I had made it very clear that please don't Google any of your health issues because you'll have to understand the human mind. When you're looking at a problem, any disease for that matter, on the net, the human nature is pulled towards negativity. So, suppose you're looking at a drug causing, probably it can cause nausea, vomiting, occasional this thing and all that. Eventually, the mind goes down deep to find out and see what aplastic anemia, agranulocytosis, and then they Google on that and see, and then they are scared, and then come and tell, sir, this can cause that. So it was a big this thing. I used to tell my patients, see, one thing you got to understand. I myself get confused. After 37 years of experience in medicine, and definitely most of my peers and my own colleagues on it, they also feel the same way. That is too exhaustive. And as one of my professors, Dr. Srihari, used to say, common things are common. So when you look at the side effects, every drug will have some side effect or the other. But is it necessarily there in every patient? One. Second, if at all if it is there, for example, when you're giving nitrates to cause vasodilatation, coronary vasodilatation, it also causes dilatation of the cerebral vessels. So what happens is in um, minority of the patients starting the drug first, they can present with headache, and some of these patients can present with intractable headache. But what happens is, after a period of time, as a few days go on, they develop tolerance to this cerebrovascular dilatation, and the headache subsides, whereas the coronary dilatation remains. So, when you're prescribing a drug, we'll have to tell that you might develop, but don't bother, it will go. And in such a case, take some pain relievers, calming agents, or whatever, but don't stop your drug. And when I remember having a heated discussion with, uh, uh, an engineer who was working with one of the multinational companies. And then this gentleman, I mean, projected to be the know all, be all, and end all of everything, including medicine. And the fact that he started telling, sir, these are the side effects, you have given me that, this, then I did not see. One thing is that as a doctor in a doctor-patient relationship, one should not lose their cool with the patient, whatever happens. So I allowed him to have his say, and then eventually told, sir, one thing, these are all chemicals. It doesn't mean that they should have all these side effects. It can. There are some common side effects. Like I said, that nitrates can be there. Or when you're taking GLP-1 agonists for diabetes, like liraglutide, semaglutide, whatever, there can be abdominal distension, nausea, vomiting, which settles in a few days. So we as doctors, we look at everything, look at the patient also, see whether they are allergic or already having a problem. Probably, for example, like I said, GLP-1, already having gastroesophageal reflux disease because of the disease itself, I mean syndrome, diabetic syndrome itself, and then only decide. Then I told him, sir, do one thing. You got your those thing, no? Google paracetamol and see what are the uh, major those things. Because definitely, I'm sure you're not going to study the common side effects which can occur rarely, but you're going to go deep into this thing. You tell me. Then he said, sir, I said, carry on. I got time. I'll wait. I want to clear this with you. Then, when he went through, sir, liver failure it is given. I said, that is it. Do you understand now? Liver failure with paracetamol, where does it occur? In whom does it occur? Whom? It can occur. Can't say it should occur. Probably a patient who has already had a liver problem, an alcoholic, already having cirrhosis of the liver or something damaged, and this gentleman consumes probably 50, 100 tablets of paracetamol, he might develop, and probably a regular alcoholic also on top of having a liver disease, cirrhotic or whatever, and then with an intention of committing self-harm, suicide, whatever, he consumes about 50, 100, 150 tablets, then there is a possibility of this gentleman developing a liver failure. So you got to understand, please, sir, stop this. Because let us do the thinking for you. If you got any doubts, you ask. Don't confuse yourself too much. Uh, this is, I'm sure all my colleagues and even my friends, non medical people, will agree with me. When you are giving, it is like when you trust a doctor, you have got to trust him fully. It is like surrendering to God. I'm not telling, but I am equivalent of God, they say. Of course, it's a sacred profession, but we are human. We pray, get this thing, and the thinking, diagnosis, everything that higher power only provides. Otherwise, with all the education, we can only confuse ourselves. So, getting to the proper diagnosis, asking the relevant questions during history, pulling things out and all that, it is very, very important. And then concluding on others thing, then your examination, you come to a presumptive diagnosis. After finishing, probably this, so we were taught, we were very lucky to have professors like Professor K.P. Mishra, Dr. Rangabhasham, who are most of them. And we were taught that not the reports, but you have got to make a diagnosis. These are to confirm, and their records are records of a follow-up. So, like that, when I was thinking about artificial intelligence in LinkedIn, few people had contacted me in the tuning of this thing. It is not going to be easy because it is dealing with human lives. whereas every other field it is different. And here again, first when you look at the broad, this thing is the cost one. Second is the anonymity. Will it be able to maintain the anonymity of the patient, which is very important. Thirdly, when you look at the commoner things which comes to mind for, you need not study medicine to think of all this, is that I, as a doctor, we are, the human kind is imbibed by God with the sixth sense, emotions, intelligence, rationalizing things. So, when you look at whether a machine or a robot or a humanoid, whatever, whether it can do that, it is something which we cannot say. One thing I'd be told for sure is that it cannot do as well as a genuine, human being as such as, or a physician or a doctor. I'll give an example. When a patient walks in, when I look at him, I have to look at his emotional status, whether he's afraid of things. It'll show in the face, tense, worried, or whether he's not bothered, careless, carefree character. So that's why I say medicine is an art. Want to start workshops on the art of medicine, practicing it as an art, observation. So when you're looking at that patient, then you start interacting with him, which is taking history taking, we say. When you say history taking, it means that it is just not gossiping. It is gradually getting him tell the diagnosis, get to the diagnosis. Talk something which brings me nearer to the diagnosis. History means he is telling a story about his problem. And then I conclude on that, or I means me and all our colleagues here. And then we come to presumptive diagnosis, and later on, after examining. See, this human touch cannot be provided by any other this thing, artificial intelligence or a robo, all those things. They can create algorithms and try to simplify things and all that. But without looking at a patient, then when I'm seeing the patient, I'll know whether this gentleman will be able to afford the cost of these medicines, and if at all somehow because of necessity is able to buy, will he be able to continue taking that, or should I give a alternative, or probably I'll tell him to have a generic version of the disease if it is required, or or push him across to a government setup or an NGO, like we do for patients needing dialysis or whatever, heart failure patients who can't afford an NGO this thing to help them out. These all cannot be rationalized by artificial intelligence. So that is one thing. There is no human touch. So just imagine patient tense, worried, patting him on the back when I'm examining and telling him, don't worry, things will be okay. You are not those things. There is no harm in lying also a bit. He might, if it is, even if it is a severe problem, bring it down a bit. Let him be happy. I have treated a patient with cancer. In a way, a colleague's father, a dentist, his father. That was in 2014. He had a carcinoma with metastasis, and then this chap, I don't want to name him, but he has become such a huge fan of mine after that. I told him, see, one thing, one person needs to know in the family about the problem so that treatment, everything can be given. You are there, you are a doctor, you are a dentist. I would suggest that that's why we call it an art. Enough if you know. Unfortunately, you passed it on to your mother. Okay, I will try to, set right things a bit. told that it is malignancy. Okay, but whatever happens from here on, let it not, don't interject and then tell it is because of malignancy. That will be the nature of both your parents. So your father doesn't know, let it be like that. Let us see, otherwise he'll be dying daily. Do you want that? Then he understood. He said, okay, sir. Then, when I spoke to his father, I gave a different thing diagnosis. I didn't speak about malignancy at all. I told his mother also, see, it is a mild thing, it is not spread, don't, no problems, it is not going to. I got the permission of the son before telling this because certain lies and this thing. Uh, for the benefit of the patient, that is much, much better than telling the truth. And then various symptoms developed. I had to arrange narcotics for his pain later on, attribute it to something else at his age. And then finally, this person, gentleman, he lived for about 4 years. Last year, during his last year, he had some pain, intractable pain, all that patches, everything was given. But till his end, he didn't know that he had malignancy widespread. And I felt good about it. I thought this is right because they had known, imagine, why I'm told that I've got a bronchogenic carcinoma, which is a small cell carcinoma. Anytime, anything can happen, spread this thing, like Valve Maya film you would have seen. Then imagine my plight. I'll be worried about the family, worried about myself, everything. Each day I'll be staring at death, and each day I'll be dying. It is not required. One person knows that is enough. That is the art of medicine. And his mother too, though she knew, gradually made her forget that this is a big problem, and then started talking about his other comorbidities causing his pain, this, that. And then eventually, finally, this gentleman passed away one day after 5 years, not knowing that he had cancer. His wife also I literally forgot that he had cancer because stress was on all the other comorbidities causing the symptoms. And after, this was 2014 or something, 2021, I got a call from this doctor. He said, sir, somehow I got your number. Thank you so very much, sir. So, in the sense, see, it is not out of ego I am telling, it's the satisfaction which you get because I have been on the other side. We will have to look at the patient's emotional aspects, financial aspects, what all issues. I should become the patient, then see what all I'll have to go through, and then decide on the management protocol. So this it became easier for me because I had been with my father even before I joined medicine, and then subsequently while studying medicine, and then later on after completing everything post graduation, this, that. Several times I've gone to various cardiologists and other people, never told I'm a doctor, just to see how things go. I am writing these things in the book. I mean, it is so very sad, but there are also very good incidents which are there. But I'm just telling how people look at a person, and then if they know that relative, somebody is a physician, those things, experience, how the approach changes, so many of these things. An artificial intelligence cannot do any of this. It can probably come to a diagnosis based on the symptoms. It might be able to ask questions, but then suppose I've seen, I've asked the patient, said chest pain, chest fear is always a cardiac or a heart attack. So I asked the patient, sir, do you have pain or do you have a burning sensation? Or how is the pain? Is it spasmodic? Then eventually you get closer to the diagnosis. If he points his finger, it means that what I think my colleagues will realize in Davidson's given pointing index, when you point out, you invariably it's not cardiac. or if it is a spasmodic pain coming in, probably gastroesophageal reflex, esophagus spasm. And I've had a close friend of mine, no, the commissioner of customs coming and telling, sweating and telling, sir, I have chest pain, and I think I've got a cardiac problem. Then getting the history I knew is that last 4 5 days he has started playing shuttle and all that. And then asked him, when do you get the pain? He said, when I move my limbs and all that, I get the pain. So it was very clear. So muscle catch. Of course, we didn't ignore. We had an ECG done, everything to prove that it was okay, or, or for his this thing. But history clinches the diagnosis. In one of my videos here, I have given on the differential diagnosis of chest pain. It doesn't mean that you should not be taking an ECG or anything. It means that you can relax a bit. Still go, have it done for your satisfaction, satisfaction of your doctor, but not panic. So this human touch and artificial intelligence, it's not possible. There should be a doctor behind to do all this. And then there is another those thing which can be a legal thing where something goes wrong. Who is at fault? Is the AI at fault or the physician consultant at fault? So there are so many of these. So I got a couple of offers to work on artificial intelligence in medicine. It is interesting, it is exciting, and I always love a challenge. So I'm sure they will come around to it, but the human touch can never be replaced by, uh, it can only be replaced by another human being, another doctor. So there should be a physician, someone guiding. Even for a robotic surgeon, somebody who guides to this thing. And then all fancy this thing, but there is no substitute for the human mind. But it makes it easier, or it can complicate things, knowing too many things. So it is all eventually left to the individual consultant, as well as the. This can become easier. How to simplify it? And imagine in a country like India with so many languages, so many dialects. Uh, it is still going to be much more difficult than West, where you got English or Arabic or Urdu or even Hindi, the northern those things. There are so many those things you'll have to create in that language, particular language. So when I was speaking with one of the, would-be recruiters from abroad, yesterday I was telling that, see, you'll have to look at it and make it into two this thing. One is a simple approach to problems. Don't go deep into everything. Give the rarest of the rare complications, or even the treatment modules will vary. I mean, not starting with the highest, best broad spectrum drug in an infection, because that is something which will eventually lead to resistance. These are drugs reserved for patients with immunocompromised patients like diabetes, those who are on long-term steroids or HIV or whatever. So here again, it is the choice of the physician. So it can suggest in these situations that probably, of course, okay, you'll know the treatment of tuberculosis is that 4 drugs and then 3 drugs if it is not a multi drug resistant tuberculosis, otherwise the second line. So the suggestions can be given, but the decision has to be made by the doctor. So these are the things I find it exciting. So I think that I'll also various those things in my life. The sense that I did my anesthesiology, then my general medicine, then diabetology, then hepatology, subsequently medical jurisprudence, so that I can argue for my own cases, because I was always interested in law. And then I'm doing my criminology now. Now looking at artificial intelligence in medicine, how to make it simple, because the definition of a genius, let us take A as a genius. Genius is one who has the ability to simplify the complicated. So that is what we want, not to complicate what is there. And remembering common things are common. Then taking into account various other factors like the patient's emotional, mental status, the financial status, various other things, whether he will be continuously able to follow up the treatment, and then the confidentiality, all these have to be looked into. So I thought I'll take a couple of days' time before I decide on taking up this person. He is abroad. Okay, the timings something, but is that we can always adjust accordingly. And I thought at this stage, when I'm doing some studies also, practice for a few hours and then working on this, because this is going to definitely come, whatever the pros and cons, and definitely at this thing, it will probably be much, much better than what I'm telling now. Only thing is that it cannot replace human touch or this thing. So with that, I think no, like I read somewhere, very senior, experienced doctor telling he is going to change everything in medicine totally. I don't think so. It might help in changing a bit, making it easier, provided that the consultant is clear about himself, and not getting complicated by things like I hardly look into the net for any of the issues unless I have got to go deep. There is no point in telling a problem which can arise out of those things. Probably when you look at it, it will be 1 in 10 lakhs. So is it worth it? You have to see. So the projection, various other things are there. So I have requested this, person who is working on AI in the US, another gentleman in Tokyo. They're all working, and what I said, I asked them, "Do I make sense?" They said, "Really, definitely, sir." In the sense that, especially in our country, I think there are a few startups here. PM is encouraging this, so looking into this will be very important for almost all doctors who, fairly experienced now, exploring into that, giving a bit of their ideas so that the whole thing can take shape and probably be of real use in management, especially of complicated disorders and other this thing. I don't think you need to have an AA this thing for regular rhinitis or upper respiratory infection or for appendix and all that. It will be an expenditure only, unwanted expenditure. But once your diagnosis is clear, you have made a diagnosis, no need for anything else to substantiate that. Probably a few blood tests, complicated things you can get this. And then this in the beginning stages. In our country, we'll have to look at various other factors like last 15 20 years. I had been putting my foot down along with certain colleagues of mine, especially with the union government, that all studies of various newer drugs should be done on the Indian population. Because when you look at the diabetic patients, we have got a genetic preponderance, whereas the Westerners don't have. And in several instances, we have seen the side effects which they have mentioned are not seen in our country much, whereas they are different here. So, all those studies, specific studies, everything should be done in our population. That itself varies because of the widespread those thing of, for example, diabetes. Okay, every Indian is a pre-diabetic with a genetic Asian Indian phenotype. But when you look at the other disorders also which go along with that, that is why we call diabetes not a disease, a syndrome. So fascinating. Let us see where it goes, and hopefully making it simpler, cheaper, and to be taken in when a doctor or a group of doctors are really confused as to a problem with a patient, then that can be used. That's what I feel, and I'm sure that our Prime Minister, probably in next week's meeting of the Union Health Ministry, I'll be discussing this definitely. And also, I am also looking forward to a tenure with the probably channelizing AI in India in the medical field. Thank you all so much. Have a wonderful night.